Beth Israel tonight. This is Hi, I'm Barbara Fisher, and I wanted to thank everybody for coming this evening. There's lots of thanks to go around. First of all, I'd like to thank Sisterhood for sponsoring this event, and I've worked with Nadine, who's been fabulous as a Sisterhood president. I'd like to thank Rabbi Joseph, who helped me think this through back in the spring. And before we start our panel, I'd like to tell you how the evening's going to go, what my inspiration for doing this was, and all of our wonderful guests here. The way the evening's going to go is there is a moderated panel, and I'll introduce our speakers as we go. I'm moderating, and these lovely ladies will be helping me by answering the questions I ask of them, and Rabbi Joseph will be giving some opening remarks. After the panel, we have a wonderful, wonderful fair of 12 different community organizations, and I'm going to tell you who's here. I am so thankful because this is really making this night special. So in alphabetical order, we have Allison Hancock from Breast Friends. If you could raise your hand or stand up. From Compass Oncology, we have several people. We have Will Winter, Nikita Sinha, Jenna Emerson, and Hannah McLaughlin. From Fighting for, did I say it right? From Fighting Pretty.
She's not here.
She's not coming, but we have a table. Just know that they're a wonderful organization in town. From Legacy Gynecology, Oncology, and High Risk Genetics Clinic, we have Amy Bates and Therese Toohey. Thank you. From OHSU Cancer Genetics, we have Jessica Kushner, who's one of our CBI congregants. Where's Jessica? Jessica. She brought with her Libby Cook and Stephanie Godel. From the Ovarian Cancer Alliance of Oregon and Southwest Washington, did they come? They are coming. They're supposed to be coming. And that's Diane and Zoya. From Pink Phoenix, I saw you with your beautiful shirts. We have Sandy and Teresa and Mary. Thank you for coming. From Sharsheret, Melanie Fisher is the West Coast coordinator. She's not here, but we have a table, and we'll talk about that in a little bit. From the Shock Foundation, we have Bruce and Terry Hildreth. Where are you? I saw you. And Yvonne and Basta. Thank you for coming. From Therapeutic Associates, one of my favorite physical therapy clinics in town, we have Jessica Dorrington, and she brought someone with her. Alina, thank you. And we have Vicki Espinosa, one of our community members who wrote a book called 1 in 8. The inspiration for this evening is people close to me have survived breast and ovarian cancer, and I am running the New York City Marathon with a Team Sharsheret bib on November 1st. So my role with the Sharsheret is twofold. One is I'm responsible for fundraising, and I need to raise $6,000. And the second role is an ambassador to spread the word what Sharsheret is, and we will be talking about that this evening. If you are so inspired, tonight is a free event, and thank you everybody for coming. But tomorrow night, with a $36 donation, you could join a virtual challah braiding event that will be happening at 5:15. Our time with the expert challah braider from Boston named Noah Hughes. And on the back is a QR code if you'd like to donate and come to the event. I will send you a link tomorrow to the Zoom, or if you just want to donate because you want to support Sharsheret. On the Sharsheret table is a wonderful piece of paper that Tracy from the office put together with all of these wonderful organizations. So if you didn't bring a pen, there's lots of pens on the tables and little pads of paper, but please grab one, and you can see all these wonderful, wonderful guests here supporting our community. Okay? So we're going to get started. So to start with, I'm grateful for the temple, as we talked about, for hosting this important conversation and bringing our community together for an evening of education, empowerment, and connection. Tonight we'll be discussing topics that can sometimes feel complicated or even intimidating, including hereditary cancer risk, Jewish genetics, breast health, screening, early detection, and the many resources available to individuals and families navigating these concerns. But this evening's not about creating fear. It's meant to provide knowledge. When we understand our personal and family health history, recognize what questions to ask, and know where to turn for support, we're better equipped to make informed decisions and advocate for others and the people we love. This conversation is relevant not only to those who have personally experienced cancer or who have a known family history, it is relevant to all of us, women and men, younger and older adults, and to families who may not know much about their own genetic history. Sometimes important information is passed down through the generations, other times it's unknown, incomplete, or it's just never been discussed. Our hope is that everyone leaves tonight with a greater awareness, practical information, and a better understanding of the resources within our community. To help us begin, we're honored to welcome Rabbi Rachel Joseph, who will be offering opening remarks and help ground our conversation about the importance of community, connection, and caring for one another.
Thank you, and thank you for everyone for fighting the traffic, finding the parking. Apologies for the Timbers game. What's happening in this very exciting part of Portland? And so I know it was a lot. And we know also that we have lots of people watching us online. That's why we moved into this space so that we could record it. And it's important conversation could be shared beyond these walls. And it's pretty amazing to have, as Barbara was saying, all these organizations in our space, but in one space. And so I hope that folks have enjoyed meeting each other and maybe cross-pollinating some of the information that we do to really support people in our area. I feel really lucky. So in a Jewish context, welcome to Congregation Beth Israel, we are in a really interesting time of year. We are only 3 weeks away from the Jewish New Year, which we call Rosh Hashanah, and then it continues onto many holidays for a month of holidays. And so we are in this season right before it. The Hebrew month of Elul is what it's called, and it's a preparatory month. It's how we prepare ourselves to get ready for the height of our biggest holidays of the entire year. And Elul really asks us to slow down. It really asks us to slow down and to notice and to pay attention. And we often think about it as internal work, as internal spiritual work. We're checking in, we're seeing how we want to change from last year, how we want to be as we're approaching this new year. But our tradition has always also taught us that our physical is just as important, that caring for our bodies is also really important work in this preparatory time of Elul, and that our health, our physical health, is not separate from our spiritual health. It's all intertwined, it's all connected. We know that our brain and bodies are connected in how we prepare. And so caring for our bodies and seeking knowledge and supporting one another and asking difficult questions and being in conversation is all part of this really important work that we do at this time, and why it's so significant to gather now, why community matters. In Jewish tradition, we say you can't be Jewish alone, and that you don't walk through life's highs and lows alone, and we do that together as a group. This evening is also deeply personal to me and something that I really wanted us to do for a long time. Thank goodness for the indomitable Barbara Fisher to pull everyone together and to make this happen. That some people know, in 2023, my closest friend, Rabbi Amy Gerasi, died of breast cancer. And throughout her illness, Sharsheret, this organization we're going to learn about, was there every step of the way, walked beside her family. And they offered not only all the practical resources, but really they provided so much comfort and so much education and so much ability to walk this as a community, really understanding how a diagnosis reverberates throughout not just the individual, but the family and everything that the family touches. So I think about Amy every day. I wear her yarmulke every day. I wish she were here tonight because she believed deeply in the power of this organization. She believed deeply in the power of education and community. And she would want every person in this room to leave empowered and full of knowledge and not frightened, but really connected and informed. And so thrilled that we can be here together to have this conversation. We know that knowledge is key. We know conversations are key. We know that understanding everything that Barbara talked about is how we save lives. So knowing where to turn for support is how we make it through. I mean, I'm just blown away by all these organizations that are here. So again, expressing my deep, profound gratitude to Dr. Fisher, who's not only an outstanding physician, but literally runs for everything that she cares about, and will just go to the ends of the earth for organizations. And so thank you for raising awareness for sure. Share it. A preemptive then thank you to our esteemed distinguished panelists, Dr. Daphna Lohr, Dr. Denise Bilbao, and Michelle Kaplan. Thank you for bringing your time and your talent and your expertise. We are so grateful for all of that. So may this evening be one of learning and hope, and may we leave with a greater understanding and deeper connection and a commitment to one another, to community, to continuing the conversation, to being there for one another. So thank you so much, and we will have our panel.
Thank you, Rabbi. So I'd like to start by introducing a couple of our panelists. To my left is Dr. Daphna Lohr. It's my pleasure to introduce her. She used to be one of my partners when I worked at Women's Healthcare Associates. Daphna Lohr is an obstetrician gynecologist. She brings an important perspective on women's health, preventative care, and the role healthcare clinicians can play in helping patients understand their personal risk and make informed decisions. Next to Daphna is Dr. Denise Bilbao, who I just had the pleasure of meeting, but I've talked to her lots about this event. She's an internist who takes care of a lot of women and talks a lot about breast health in her role at Kaiser. She brings expertise in breast health, screening, prevention, and helping patients navigate the many questions and decisions that can arise around breast cancer, risk, and early detection. So I'd like to start with questions for both of you. Michelle Kaplan is a community member. We'll get to her soon. I did not forget you, okay? So for Doctors Lohr and Bilbao, I'd first like to ask each of you to briefly share what brought you to your area of medicines and why conversations about cancer risk, prevention, screening, and patient education are especially meaningful to you.
Thanks, Barb. Okay, I'm going to look at the question because I want to make sure I answer it properly. There we go. What brought you to your area of medicine? Well, let's see. Quickly, my background is that when I started my educational journey as an adult, I'll say I was not planning to go to medical school. When I was young, everyone in my family said I should go to medical school, and I said I didn't want to. And they basically said that because I was good in math. And then I ended up with a degree in biomedical engineering because architectural engineering disappointed me in college. I was a biomedical engineer, and then I went to medical school. When I worked in biomedical engineering, I worked in cardiac electrophysiology because I thought it was really interesting. And then when I went to medical school, I always was somewhat interested in women's health care, but I didn't really see myself as a surgeon. And then when I did my surgery rotation, I really liked surgery, so I ended up in obstetrics and gynecology. I also kind of joke that I think that women's healthcare is special. At the time, not so much anymore, but when I was in my 20s, I was easily bored, and so I liked to multitask, and obstetrics and gynecology is probably one of the most multitask-filled medical specialties. I had a student shadowing me today, and we saw patients in the office, and then we ran across the street and delivered a baby, and we pre-oped 3 patients that I'm going to do GYN surgery on Friday, and I was reading ultrasound over my lunch hour. So that's how I ended up where I am. Women's healthcare, I think, just organically feeds into preventative medicine and to cancer awareness just because of how the flow of healthcare goes. I mean, my basic wellness visit is, most people don't even know why they would even come and see me if they weren't due for a pap smear this year, which isn't even what we're talking about. And I say, well, we do a lot more besides pap smears here in the GYN office. Pap smear is a screening test that we use to screen for risk factors for cervical cancer. And so a lot of patients think I'm their primary care doctor. I am not. But they're like, but you're the only doctor that I see sometimes. So I do see myself as basically, if I'm the only person that a patient chooses to see regularly, even if I'm not her primary care doctor, which means that if she has an ear infection, she's out of luck with me, then it's my job to screen her and be the preventative care gateway. So for example, all my career, I'm the one who oftentimes is like sending people for their mammograms or screening them for cervical cancer or screening them for lipid disorders, even though that might not be my area of expertise. So that's kind of how I got here in terms of my career. On a personal note, in 2024, I was diagnosed with breast cancer. And it has been a very, very interesting experience to be a cancer patient after being the person who has screened hundreds and thousands of women for cancer. So Will Winters in the audience today, he's a GYN oncologist in the community. He was my attending when I was a resident, and I have sent so many patients to him over my career. And I think that to experience navigating the oncology world as a patient, it was so challenging and confusing to me at certain times. My decision making that I had to make, I was like, wow, I'm a physician and I am really struggling to understand some of these choices, and I'm really struggling to understand what's the right thing to do here or who should I see here. And so it really was very eye-opening to me and taught me a lot. And so now if I have a patient who I have found her cancer either on exam or in a screening modality like a breast cancer, she'll say to me, I don't really know what to expect. And I say, well, I can help you a little bit with what to expect more so than I was before. I don't think that you have to have experienced the medical condition to be a good doctor or care provider, but it did kind of give me a newfound understanding of what my patients go through and kind of reinforce my commitment to this type of work.
Thank you for sharing that.
Sure.
Yeah. I think of you as some of our primary care colleagues, so even if you don't identify as a primary care provider. I know. I'll look at your ears for you. Yeah, that's fine. It's, like I don't deliver babies. I don't know how you do it. I was so glad that Rabbi was wearing her Amy's yarmulke because I was very touched by the story you told, I think it was a couple years ago, of her illness. And I also had someone very close to me pass of a cancer very young, and my sister was diagnosed with breast cancer, and I think someone in here wrote a book called 1 in 8. So it's really something that touches us all as people, as family members, as friends. And so that really kind of lit the fire under me that I needed to learn more as a clinician about genetic predisposition to cancers. And for a while there, we had the Healthy Oregon Project, which offered free genetic testing for Oregon residents. So I became a proselytizer for this service, and everybody I sent to it. And I was shocked by how many people came back with positive findings, colleagues, et cetera. So that was kind of another journey of like helping people navigate uncertainty. They have risk, or maybe they have family history, like Daphna was explaining, but they don't find a gene, so that's part of what brought me to this work. As a physician, I also insisted to my family I was never going to be a doctor because everyone in my family was a medical person, and I just didn't see that for myself. And so I was an art major in college, but I wasn't very good at it. So I had to figure something else out. And the thing that really helped me was I volunteered at Rhode Island Hospital as a translator because my parents were both Spanish, so I could speak Spanish. And I realized, finally, here's something I can do. I can help people navigate the healthcare system who don't speak English. And then later, I had an experience in a county clinic with a provider who was bilingual, and she was so busy and did so much work, and I said, that's what I want to do. I want to be a primary care doctor for people who can't speak English, and that's kind of what I do now. And I've been doing it for 14 years at Kaiser, and prior to that, I worked at a county clinic in Oakland. So yeah, this comes up all the time as a clinical problem and also a personal issue.
Sharshara was so fabulous of helping me with a script, but I really want to introduce Michelle, so I'm going to skip to the bottom and then come back. So if you could introduce yourself, we'll come back and talk about Sharshara at the end. But if you would be so willing to share your story, and then we can come back to this. Would that be
Absolutely,
okay?
this on. Thank you. Thank you for inviting me to. Thank you for. We got connected, which was amazing, and so I appreciate that you asked me to be part of this. And just listening to you talk about your role in both as a survivor now, but also as a doctor. My story is that I went to my OB for my regular checkup. It was a normal day that I was going to cancel the appointment because I was too busy and I didn't want to go, and I was like, I can just reschedule this and I don't need to do this. And 6 months before, I had had a mammogram and everything was fine. And I have a history in my family. My grandmother had breast cancer. She was postmenopausal, and my mom's sister had it as well, postmenopausal, and my dad's sister also postmenopausal. So there was a history there. So there was, it certainly was a possibility. And she was doing her exam, and we were chatting away, and all of a sudden, her facial expressions just completely changed. And she said, kind of, do you feel that? And I said, well, now that you mention it, yes, I do. And I'd done my self-exams, but it was in a really weird, one of those precarious spots that sometimes you can't feel everything. And it started the journey. And it was I was 47, it's been 10 years. I just hit the 10-year mark. I'm gonna be 58 in a couple weeks, and it's remarkable that it's been 10 years, to be honest with you. It turned into a lot of appointments, a lot of what do I do? How do I do this? And Sharshara was one of the organizations that was there for me. And I was on the way over here. I was trying to remember how I initially got connected, and someone in the community connected me with them. And it's what we do. We take care of one another, and connected me with them. And the beauty is, you know, they immediately talk to you and they figure out how they can help you. They also connected. I have a very close friend here in Portland that connected me right away with Breast Friends, and Allison, and you know, I don't remember if it was you I initially talked to, but it was having that support in this community made all the difference in the world. And I ultimately had a double mastectomy and had reconstructive surgery. And this past April, I found out that in February, knowing that the 10 years was coming up, I went in for a checkup with the plastic surgeon, and she had me go in for an ultrasound, and both breasts had decided to rupture, so I had to have them replaced in April. It sounds scary, but it was actually totally fine. It was a really so much better than I thought it could have been. So I was grateful for that. So I'm here. I'm healthy, and I feel like my goal in life is to educate and to help those to navigate this journey, because it is not easy. So that's my story.
Thank you for all of you for sharing, and especially for the two of you for sharing your personal journeys and being vulnerable and sharing that with us. Thank you. I'd like to move on and talk about genetics, because Sharshara is an organization that supports people affected with cancer, and also people who may know they're at risk for cancer, or they don't know that they're at risk for cancer. So let's talk about Jewish genetics and hereditary cancer risk. Dr. Lohr, I'm going to call you Daphna. When we talk about hereditary cancer, what does that mean? How is an inherited genetic risk different from cancer that develops without a known inherited mutation?
That's a broad question. So what we're kind of talking about is some people carry a gene mutation or a change in their genetic makeup, their chromosomes, that predisposes them to cancer. And this is a scary thing. I think for some people, so I'll give you an example of my family. My family has a huge breast cancer history. And long ago, when I was breastfeeding my now 16-year-old, I developed a benign tumor in my breast, and I went and saw a breast specialist. And she looked at my family history, and she was like, wow, have you ever seen a geneticist? And I said, no. And she said, I think you really should. You have a big family history. And she referred me to Teresa. It took me a really long time to go because I was a really busy obstetrician gynecologist, and I actually didn't go until COVID because I was like, wow, I have some time. And what really was compelling to me is I was like, I got to find out what we have in our family, is that my testing came out negative. There was not a known gene mutation that explained the cancer in my family. And I remember very clearly what I was told is that there probably is a gene mutation in your family. We just don't know what to look for yet. So some people have a family history, and they have to decide if they want to know if there's a genetic mutation that runs in their family that we can test for. It's a really loaded question because the question really isn't, it's whether you have it or not is not hard. You go see an expert, and they recommend a panel, and they test you. The question is, what are you going to do with that information? Do you want to know if you have a gene mutation? Because what's going to happen is that once you know that you have this gene mutation, you're going to learn what that mutation means. It means that you are at increased risk compared to the general population for one or more cancers, and then you're hoping that there's something to do about it. So the one that that most people know about is BRCA1 and 2. So people who carry the BRCA gene mutation are advised you could increase the frequency of your screening, or you could increase the type of screening that you have for breast cancer. We really don't have a screening test for ovarian cancer. So what do you do with that information if you're at increased risk for that? Some women would say, I would choose to have preventative surgery by either removing my fallopian tubes. Did anyone here read the New York Times? We're such a hot topic on our fallopian tubes right now. So removing your fallopian tubes reduces your lifetime risk of ovarian cancer. Some women say, I want my ovaries removed. When should I do that? Am I going to go into surgical menopause at 40 to reduce my risk, or should I wait till I'm menopausal? So it's complicated because what you're asking is, does this person have a gene mutation that increases their risk of certain cancers, and is there something to do about it? So some people are like me. I was expecting to find something, and I had nothing, but I got cancer anyway because we don't know what to look for. And then there are some people who don't have a strong family history or really any family history, but they are found to have a gene mutation either because they're looking for something else, or they did 23andMe, or some people don't know their family history because they're adopted and they want to test and find out. So it's like this really, really big field and a hard question to answer, which is why we have experts called genetic counselors. All my patients who ask me to test them, I've never ordered a genetic test. I'm like, you have to go to a genetic counselor. Why? I know what I want to be tested for. Because I want you to hear what you're going to do with that information. And that information comes from somebody who all they do all day is read the data and learn about the data and know what to tell you. So I think that the important thing is knowing that just because you don't have a family history doesn't mean you might not be a carrier. Just because you do have a family history doesn't mean that you are automatically known to be a carrier. But some people are like, I actually don't want to know this information. But for those of us who do, it can affect how you screen yourself, and it also, if you are diagnosed with cancer, can affect the treatment choices that you might make. Some people who find a small breast lump might be candidates for something like a lumpectomy, just removing the lump and doing radiation, but if they learn that they're at an increased risk for recurrent cancer, might choose a mastectomy instead, so your cancer genetics can influence your medical decision.
Thank you.
That's a lot of words, sorry.
I just want to highlight several of the tables are filled with genetic counselors. If you're a genetic counselor, can you raise your hand? So the genetic counselors probably get together and they are in a bigger grouping of genetic counselor, but for me, this is like the most genetic counselors I've seen in one place, so we're pretty lucky. Thank you all for coming. I also want to add, and then I'll ask Denise some questions, that I'm a maternal fetal medicine specialist, so I take care of pregnant people. And that people might ask, what if I find out I have this mutation? Do we test my children? Do we test my pregnancy? This is a very complex adult conversation. And it is not ethical to test fetuses. It is not ethical to do an amniocentesis unless you're going to do something different. It's not ethical to treat children or to test children, screen children. That this is an adult conversation, and we test for conditions when we might do something different about it, like change of screening or like surgery. So just, this is really an adult thing, not a kid thing or a pregnancy thing when we think about our offspring, but I just had to add that in, being a high-risk obstetrician. But Dr. Bilbao, do you mind telling us why is this important for our Jewish community to be aware of hereditary cancer risk, especially Ashkenazi Jews?
Yeah. Oh, thanks. Well, the geneticists in the room will appreciate how much I learned in a very short amount of time about the Jewish ancestry clusters, which are very complicated, right? What originally kind of spurred me to say to Rabbi, hey, we should talk about this in our community, was learning that, 2.5% of people of Ashkenazi Jewish background carry some genetic predisposition, which is a big difference from the general population, more like 0.2%, right? So that's like 3 out of 100 people. So that seemed like a lot to me. And that's just one of the ancestral clusters, right? We have Sephardic Jews, we have North African Jews. I mean, it's really a rabbit hole. And, I started to make tables of all the genes that are associated with each cluster because that's the kind of person I am. And then I was like, whoa, no, I don't need to do that. That's the job of the geneticist. The other twist, I would say, and Daphne and I were talking about this because Kaiser has a different system. It's an HMO, right? So there's a lot more rules that govern the care that we provide. One of the things we run into is, well, what if you have a Jewish background but you don't have a family history? And at Kaiser, you don't get to get referred to a geneticist if that's the case. That may change because the other thing is doctors don't always agree, right? So United States Preventative Task Force says, yes, you need both. You need family history plus the background, whereas the National Cancer Network says, no, just having the background is enough. So we were talking about the differences where you can refer, and then it kind of is determined by their insurance coverage, whether there's coverage or not, whereas in my system it's a little more rigid, and in which case then we have more uncertainty, which is should you use a commercial company to, and that's where being your own geneticist is very difficult, right? Because you don't know what you're testing for. A lot of these companies are very limited in what they offer, and sometimes we get false reassurance, right, with false negatives. So that's just another area. But I do think because these ancestral clusters have traditionally intermarried and been more insular, that's part of why some of these genetic predispositions are more common. So that's the main reason for thinking about it in our community.
Thank you. Before we move on to the next topic, do either of you have anything else to add related to genetics? Are we good? So genetics can help us understand our risk, but it's only one piece of the larger puzzle. Whether or not someone has a known genetic mutation, understanding our bodies, recognizing changes, and staying current with appropriate healthcare are important. So let's move on to things we can think about. And I know we've focused a lot about breasts. I'm going to add a couple things about ovarian after this. But Denise, what are some of the changes in the breasts that should prompt someone to contact a healthcare clinician?
Oh my gosh, I was so glad to learn about Breast Friends. I'm going to give a plug because out there they have a little card that has an egg carton full of all of the lemons that have the different changes that happen in the body. And I was like, this is such a beautiful visual, right? It's changes in the skin can be a cause. Changes in the nipple can be something that you should be aware of. Obviously, a lump, we all know about that. Some people come and ask about breast pain. Is that a symptom? There's some things that we worry less about. Breast pain is one of them, right? So I would encourage you to take a look at that table and grab a brochure and grab a little card because I think they do a really good job of doing that. But I tell people if they have a worry, that's kind of why we're in primary care. That's a big part of our job is to be someone's partner in their health journey and decide whether to worry with them or not. So I don't really have a, if this is the symptom, come see us, but otherwise don't bother us. I think if you have a worry, it's a good idea to talk to somebody about it.
I'm going to echo that. Someone close to me asked me while they were standing up, can you feel this? Is there anything here? And we were not in any kind of healthcare setting. I'm like, I don't feel anything. We were busy. It just like wasn't even on my mind. I wasn't in doctor mode. 6 months later, remember that lump I asked you to feel and you didn't feel it? I just forgot about it myself, and then I felt it again. Stage 1 breast cancer. I felt sick. It just like felt so awful and responsible. If you think you feel something, go see your doctor, please. Please, 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 because it's so much better to have it be nothing than to wish you got seen sooner. So that's my plug. Daphna, can you tell us a little bit about ovarian cancer? Ovarian cancer doesn't always have symptoms. The symptoms are very vague, and they can overlap with so many things. Subtle overlap, it's nothing. Like, what kind of things might someone with ovarian cancer present with?
Yeah, I can tell you a little bit about ovarian cancer. So, unlike breast cancer, one of the scary things about ovarian cancer is that it doesn't have a screening test, and it also usually doesn't have early signs or symptoms the way that an endometrial or uterine cancer might have. So ovarian cancer symptoms, the patients that I have, like as a benign gynecologist, the patients that I have suspected to have ovarian cancer and then found usually presented with pretty vague symptoms. Early satiety is a big one, like all of a sudden I eat a little bit and I feel really full and I don't feel good when I eat. Bloating, pelvic pain. I do a lot of pelvic ultrasounds that are thankfully benign in my patients because early satiety is a specific one, but bloating and pelvic pain also comes from constipation, which is one of the most common symptoms in postmenopausal women. And it's really, really scary. So that's the hard thing about ovarian cancer is that it is more frequently diagnosed at a later stage because of the lack of good screening or reliable screening and because of the lack of an early sign. And I think that my hope is that I think things are advancing. The other thing about ovarian cancer is that there are a lot of different kinds of ovarian cancer. There are certainly more common kinds than others, but some people have really rare presentations of ovarian cancer that have to do with different types of proteins that are expressed on the tumor. A really common question I get in my practice is, I'm really scared about ovarian cancer. Can you check a CA-125 for me? Or my primary care doctor checked my CA-125 and it's a little bit elevated and I'm freaking out this much. And I always kind of take a breath and pause there the thing about a CA-125, for example, is that it's not a screening test for ovarian cancer because there are ovarian cancers that are CA-125 negative. So you could have ovarian cancer and have a negative CA-125. And there are also a lot of other things that cause your CA-125 to go up even if you don't have ovarian cancer. So this is an example of where it gets confusing. And so I'm a worrier, and in my job, if I have a patient who is concerned, I'm usually pretty quick to get her a pelvic ultrasound, do an exam. You're supposed to do it in reverse. Do an exam, do a pelvic ultrasound, and reassure her that her ovaries look and feel normal. But we don't have a whole lot else that we can say to everybody, like, go do this and you can feel reassured. So that's the hard thing about ovarian cancer.
I'm going to follow that up with a question. It sounds like if I had vague symptoms, I'd be really well taken care of by you, but not everyone in this room has you as their doctor. How can people communicate these vague symptoms to their doctors or their clinicians so that they are being taken care of and worked up or evaluated appropriately.
That's when you just have to advocate for yourself. Yeah, I know you think I'm crazy and I'm probably just constipated, but can you just do a pelvic exam or refer me to somebody who can? Or can you order a pelvic ultrasound? Or is there a way for me to evaluate these other symptoms? I think that overall, the barriers to these kinds of things are some primary care doctors do pelvic examination and some don't. And some people have more access to care than others. But if you do have the access to care, then those are the basic things that you would start with. I'm looking at Dr. Winter because I know that there's all sorts of other things that could be an indicator for ovarian cancer. Ovarian cancer is vast. But I think that just advocating, and I think that sometimes people are in a clinical setting where they're being told, we don't have an ultrasound in this office, or I don't do pelvic exams. And you can just say, okay, great. Can you send me to somebody who can? Because there is always somebody who can. You just have to ask for it, and sometimes you have to wait.
So take home, ovarian cancer is very tricky for all of us as clinicians because it's very vague, lots of overlap. But what about breast preventative care, surveillance? Is that like ovarian cancer? Is there something we can do differently, Denise?
I mean, I think you had a story that you had had a normal mammogram, and then 6 months later, my sister had had a normal mammogram. A year later was stage 2 breast cancer. So I think the only hard thing with breast cancer surveillance is to make sense of differing guidelines. It's kind of annoying. You know, you have the American College of Radiologists, you have the American Colleges of OBGYN, United States Preventative Task Force. I think right now we're erring on the side of screening earlier and more often, right? So age 40 every year, every 1 to 2 years generally. And then also there's the challenge of what kind of mammogram, right? We have 2-dimensional mammograms, we have 3-dimensional mammograms. If you have dense breasts, sometimes they recommend alternating MRI and mammogram. So it really is something hopefully your primary care provider is up on and following guidelines around. So I think we do the danger is, of course, false positives, or I just saw 2 people today, both of whom had kind of traumatic biopsy experiences. Didn't have cancer, but, you know, I like to say the worst job is probably a breast radiologist because you have to find white dots on a white background, not what I would want to do with my day. It's very stressful. And so I think often there's this desire not to miss anything, right? Because delay of diagnosis in young women is probably the number one thing that we get sued for, with probably good reason. And so we probably overcall it since we start earlier, but that's the trade-off. So yes, we do have a tool, unlike ovarian cancer, to really screen for things. Probably too good of one.
Thank you. We're gonna move on from the physical, who's at risk, what questions to ask about genetics, screening, diagnosis, to community support. So thank you so much, Michelle. I already introduced you, but we know that cancer affects us. It affects the people around us and the people we love. And I'd like to talk a little bit about Sharsheret. I'm running on Team Sharsheret, as I mentioned. Sharsheret provides free, confidential, and individualized support and resources to women, men, and families facing breast cancer, ovarian cancer, or elevated hereditary cancer risk. There's a Sharsheret table with lots and lots of information, and please feel free to grab a pen, a lip gloss, all the stuff. But Michelle, can you tell us a little bit more? I would love for you to tell us a little bit more about how Sharsheret helped you. And I'd like to credit Michelle with all these tables, because Michelle said, you know what? Why don't you call this person at Breast Friends and call that one? And then it grew and grew and grew like a pyramid, like an upside-down pyramid scheme. So Michelle, I think you
made it
besides
happen.
being an expert in Sharsheret, probably know a lot about these organizations. And if you could tell us how they helped you get to 10 years
You know,
with
it's
a smile.
for when you are experiencing something that you have never experienced before, and you're someone like me who is very outgoing. I know people. I'm very involved in the community. I'm always the one that everyone comes to for help. And all of a sudden, I was like, what do I do? Who do I go to? Because it was such a strange place to be, to not know the answers. So my husband and I both were like, okay, we're going to figure this out. We're going to ask all the questions. We're going to see multiple doctors and get multiple opinions. And through that process, just in those first few months within the first month that I had my surgery, I was connected with Sharsheret, and they were amazing, sent me so much information, a little overwhelming, but information to help navigate all this, what I'm going through, the questions that I need to ask that I might not think of when I'm going in to meet with my surgeon or with the plastic surgeon, and deciding whether I'm going to do a single mastectomy or a double mastectomy, and what the benefits of doing one over the other are. And I went through the genetic testing. My daughter actually joined me in that process because I knew that if it impacted me, it was going to impact her, and it was that was scary. And I did not have the genetic testing. And interestingly, in the current state, my father's had a lot of health issues, and he's doing great right now. But he is going through some new genetic testing trying to figure out what's going on, because we've had a lot of cancers in our family. So it's being an advocate that you were talking about. It's asking a lot of questions. It is relying on people who know the answers and not being afraid to reach out to them. And sometimes we're scared to ask for help. I'm one of those people who does not like to ask for help because I think I can do it all myself. But I learned that I needed to ask for help. And Sharsheret was there. Breast Friends was there. I went on the Dragon Boat in that first year, and that was an incredible experience, and just never quite figured out how to fit it into my schedule on a regular basis, but I loved it. And it's community. It's being with people who understand what you're going through, and in the breast cancer community, but also in the Jewish community, because there's a spiritual side of this that you struggle with, and you say, why did this happen to me, and why me? And Sharsheret also filled in a lot of those, they have a lot of seminars and webinars throughout the year, and really are an incredible resource, especially on that level. And I'm grateful for that. And the clergy at Neve Shalom and the clergy here at Beth Israel, we all work together, and because we need to support one another. So over the years, people call me, or I'll get a call from someone that I haven't talked to in years, and they'll say, I need help. And someone just recently called me, and I was trying to make the connection on how we were connected. Someone had connected us. So there's just a lot of, you become sort of while you all are the medical experts, you become sort of the community expert in a way to help navigate both the breast cancer community, but also the Jewish community in this sense as well. And it's made a huge difference in my journey and how I am. And now it's part of who I am. It's changed who I am, and it's important for me to educate. And I too we all have had either family friends or family members or friends that have passed from the disease. And I had a friend in Dallas, a childhood friend of mine, who did not get connected to Sharsheret quick enough, and by the time she did, it was too late, and she passed. And so I do a lot of the work for people like her as well.
Thank you. I'd like to open up to the audience. We could talk all night about these things, but I'm being mindful of time because I want people to have time to interact with our wonderful tables and local supportive organizations. But I'd like to open it up to the audience. Are there questions? Jessica? Hold on, I'm gonna give you the microphone.
Yeah,
so people
good
know.
idea.
Thank you.
So I've been out of really this particular field of genetics for a while, and so my prior experiences were a long time ago. My question is, if you have any sense of, do doctors know this stuff? Okay, I had a friend who was diagnosed with ovarian cancer at 29, right? And this was over 20, almost 30 years ago. and was told things like, you're only 29, you can't have cancer. Or, oh, it's on your dad's side, well, then that is irrelevant. So I just wonder if I'm curious if you have a sense about that. Has knowledge increased for the typical OBGYN or primary care provider?
Do we know anything about this if we don't have personal history? I did not know enough until I had somebody in my life directly affected. And then I was like, whoa. And it was a young person, you know. And then Healthy Oregon Project came around, and then I was like, it is an epidemic. Like, what is going on? And so I personally, at least in primary care, it doesn't really come up as much as it should. So I don't think so. I think if you come to your clinician, it's a good thing to bring up. And, you know, when you look at the ACOG, the obstetricians have a list of, you know, family history, and it's quite extensive. You know, you could have a grandmother with ovarian cancer, one, and that's enough to buy you, even at Kaiser, a referral to genetics, right? I know, I can make fun of Kaiser, it's fine. But I've worked there for a long time, I'm an advocate, but they struggle sometimes on things. So, you know, that's my experience. I don't know what.
Yeah, I think it depends. I think that my answer to you is it depends on the type of doctor. It also depends on where we are. I think we're pretty lucky to live in the bubble of Portland. We actually, even though we're I think that Portland is a big town as opposed, and sometimes it's a small city, but we actually have a pretty rich medical community here. And I think that there are a lot of resources. I think that if you go, so I think it depends on where you are. I also think that the answer is probably different now for people younger. I mean, I finished medical school in 2004 and I've been practicing since 2008. So I think that things are very different now, especially because people do have access to genetic information commercially, the whole 23andMe, you know, movement. I mean, I have patients who come to me and they're like, do I really need to do anything else because I have this information? And the truth is that I had to do that research. I had to actually call a genetic counselor, one of the genetic counselors at where I work. These are not cancer geneticists, but they're OB geneticists. And I was like, is it the same? I'm sorry. And they're like, no, it's not the same. So I think that there is a growing awareness in the medical community, but I think that it doesn't organically come out of medical training. And so I learn from my patients every day. And I learned that from a patient who asked me the question. I didn't know the answer. So I think that it depends where you are, but there might be people in your life that need to advocate for that.
Other questions from the audience? Thank you, Jessica. That's a great question.
I'd just like to have somebody mention the categorization of a high risk, which allowed my daughter to get much better coverage of screening, and her breast surgery was just this year. So by knowing you're in high risk, categorizing that so you get the coverage that you need.
Hi, my name is Vicki. I don't have a question per se, just a comment. I'm here supporting my friend Vicki, who wrote the book 1 in 8. Highly recommend it to everyone. But I do have a background in cancer research. I work at OHSU at Night Cancer, and something that you touched on with genetics is so important about prevention and screening, but in the area I work in is actually in treatment. So having the genetic information also opens up potential treatments for people, just based on your inherited or genomic testing, but also there's tumor testing that they can do that also opens up a huge range of potential treatments. So just a comment, I know there's so much information to cover, but I just wanted to throw that out there too, that the genetics also provide opportunity for treatment.
That's a great thing to bring up. It's actually really confusing to a lot of people who I've had patients say to me, I'm really confused. I was told that I have cancer, and then my oncologist said that they couldn't tell me what my treatment would be because they were waiting for my genetic result. But I already had genetic testing with a genetic counselor, and I know that I don't have a gene mutation. So what are we waiting for? And I think that that's something that a lot of people get confused about, is that they're waiting for the genetic testing on your tumor. And there are markers on the pathology or markers that they're looking for on the actual tumor, and that's a completely different thing. And it's kind of fascinating how much it guides people's treatment, the decision on whether or not they should have chemotherapy or what type of chemotherapy is really more and more driven by the testing for genes and protein expression on tumors. It's actually kind of fascinating. Thank you for bringing that up.
Thank you. I'm going to ask each of our panelists one last question so we have time to interact with all these wonderful guests. For Daphna, what is one action someone can take to better understand their personal or family health history?
Oh, yeah. Just one, yeah. I would say just try to talk to your family members. I think that, not to stereotype, but I think that in older generations, and I can say this as somebody who is 100% Ashkenazi Jewish, I always think about the movie Brighton Beach Memoirs, how they would whisper their medical problems because, but like people don't talk about it. And I have so many patients who say, I don't really know what my grandma or grandpa died of because nobody talked about it. And so you really have to push. Or I know that my mom on the East Coast has ovarian cancer, but I don't know if she had genetic testing. Well, can you ask her? Ooh, maybe I'll ask my sister to ask her, but you have to push for it, because if you're gonna go see a genetic counselor, the more information that you can give them about your family history, the more you're gonna get out of the visit.
Thank you.
Be
Denise,
pushy.
what is one thing people should remember about screening and breast health?
You didn't hear her second one, which is be pushy. I actually think being your own advocate is really important. You know your body very well. I think as we get older as clinicians, we learn to trust patients. We are taught that, but when someone comes to you and they come a second time with the same thing, that's like a major, and also a lot of these tests are easy, like ultrasound. Here in Portland, they're not that hard to get. So I think trust yourself. If someone's being dismissive, find someone else.
Great. And Michelle, what is one message you would share with someone facing cancer or genetic risk for cancer?
Ask questions. Ask lots of questions. Take someone with you to the doctor, because it is so overwhelming getting that information. I always had somebody with me, whether it was my husband or a girlfriend, or when my parents were here, one of them would come with me just to jot down all the information. I still have that notebook that has all the information in it. And it's huge. Your head is swimming and you can't process anything that's being presented. So it's really important. And reach out to your community. Your community is here.
Thank you. I'd like to close by thanking our wonderful panelists for their expertise, experience, and insights. I'd like to thank Rabbi Joseph for being here and helping with this wonderful event. We hope that you leave with some information. I hope that you don't leave yet, that you come and visit our tables and have some snacks and learn from all these wonderful, wonderful community resources and take home some swag with you. It looks like there's lots of good stuff over there. Thank you.
Thank you, Barb.